935208. 935208. గౌతమ్,
Yes, sir.
ఇప్పుడు ఇది ట్రాన్స్మిట్ అవుతోందా లేదా?
Yeah, yeah, అవుతుంది.
అవుతుందా?
Yes.
Hi, sir. Good evening.
हाय, गुड इवनिंग, हाउ आर यू?
I'm fine, sir. How are you, sir?
परफेक्ट। एक बार तू ब्रीफिंग कर दे। अभी आई थिंक मेजोरिटी ऑफ पीपल हैव ज्वाइंड, आई थिंक 85। कितना गौतम, कितने लोग? 85 ना?
Yes, sir. Yes.
हाँ, तो एक बार प्लीज जस्ट ब्रीफ कर देना ओनली।
ఇది ట్రాన్స్మిట్ అవుతుందా లేదా? యా యా అవుతుంది.
అవుతుందా?
बट सर वहां मैं यहाँ बोलूंगा तो उनको आवाज चली जाएगी उधर।
या आई हैव लॉग्ड इन एज ए स्टूडेंट आल्सो।
नो, मैं समझा नहीं सर, वो तो स्ट्रीम हो रहा है, दूसरा स्ट्रीम है क्विज वाला।
नहीं 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 नहीं, देर इज ए विंडो वेयर देर इज ए दिस जूम आल्सो इज बीइंग टेलीकास्टेड देयर, बिकॉज जो
अच्छा,
इनॉग्रेशन
तो बट
करेंगे
वो
वो सब होगा, तो दैट विल बी देयर डिस्प्लेड इन पैरेलली इन द सेम विंडो।
अच्छा, तो वो तो जब लाइव जाएंगे तब होगा ना। अभी तो हम तो ऑफ ऑफ है ना तो शायद।
No, no, sir. We are live. We are streaming in YouTube.
ओके।
नहीं, बट वन सेकेंड गौतम, वहां पे विजिबल नहीं है। ओनली वीडियो टेक्नोलॉजीज करके आ रहा है बस वहां पे।
Can you refresh once, sir? Refresh.
वन सेकेंड, जस्ट लेट मी डू ए रिफ्रेश। या ओके ओके, आ रहा है, ठीक है।
Can you also tell in the group to refresh?
Current logins, how many?
85, sir. 85.
ये डमी क्वेश्चन का कितना मिनट रखा, कितना सेकंड रखा है? 30 सेकेंड्स।
Few are
गौतम,
30, few are 30, few are 60, sir. Just like how we have it.
नहीं नहीं, फॉर डमी क्वेश्चंस आल्सो।
Yes, yes.
डमी चलाओ एक बार।
Should I start, sir?
स्टार्ट स्टार्ट।
It's done, sir.
Yeah. Good evening, sir.
Good evening, Hari bhai. क्या हाल है? How are you?
Fine, thank you, sir.
Okay.
अरे गौतम,
Yes, sir.
can you? We will do again from the first ones
Okay, sir.
because some of them have not been able to actually. Maybe it started late. So you start from fresh. Click on this to start the quiz करके एक बार dummy again restart करो.
Okay, sir.
Just reload it again.
Hello, good evening, sir. Good evening,
Good
Jabbar sir.
evening, Pranakandi. How are you?
I am fine, sir. Thank you.
Where are you sitting now, today?
Sir, in my chamber right now.
Yeah, good. I hope everything in full swing, right?
Yes, sir. Yes, sir.
Where is Deebai? Captain
Hello,
Deebai?
sir. Hello, sir. Very good evening.
Namaste.
Good
क्या
evening.
हाल है? All the best. May God bless you. Okay, I'm just viewing it. That's all, right? Okay.
We are,
Tomorrow we'll have a small chat. Okay.
जी sir, जी sir. So you will be there for the inauguration, right?
That's tomorrow, right? Tomorrow,
Sir,
10 o'clock.
tomorrow is also there, and today also we are having a
I
short
think today it's very slightly different. There's no shoes, okay? And
Okay.
I'll be here anyway. Okay?
Okay. Thank you, sir. Thank you.
All set, right? Good. Okay. Good work. Keep it up. Okay.
Thank
I'll be here. Okay. Any technical hinges? Till now, there is no issue, right?
No, it's running smooth. We are also streaming live. There are two streams. One stream, the questions are being shown,
Yeah.
and one corner, this is also being linked, zoomed live to all the participants.
Can we see the students also? No, no. We can see only questions, right?
Yes, yes. We can't see the students.
Yeah. Okay. No worries. I'm here. Okay.
Thank you. Thank you.
सुबोध भाई क्या हाल है? Muted.
Yes, sir. Good evening, sir.
Good evening. How is the Mausam there? Your
It's
place? Good.
pretty cold.
Acha, here in Kerala, it's burning even now. It's
Right.
very bad. I think something fishy is happening. Now temperature is around 38. Very, very unusual in the month of Jan. I don't know. Anyway, so bye. Okay,
Yes.
go ahead. I'm just witnessing it. Right? Okay.
Okay,
I'll
sir.
be online all the time. Okay, Ranak bye, Deep bye, Hari bye. I'll be here. Okay.
Sure.
Yes,
Thank
sir.
you.
Sure, sir.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
गौतम कितने लोग हैं अभी टोटल?
$92, sir.
All students, good evening everybody. Hope you have a system uninterrupted net connection in place. First point. Second point, there is once the quiz starts, nobody has control over it. If you log in, log out, all those things, the only thing accessible is your WhatsApp. So don't preferably have anything which is going to have the disturb the flow of the situation. Number one. Second thing is there are total 100 questions. So it's a long drawn affair, almost about 1.5 hours. First 50 questions are about 30 seconds timer, and next set of 50 questions you will have 60 seconds timer. You can answer even before that timer finishes. Why I am repeating this is the score will be automatically calculated based on the number of correct answers and the time frame with which you have given the correct answer. So both things are important. One is giving correct answer. Two is giving early than others. If there is a tie, the system will pop up only the ones who have given it in a shorter time frame than others. So that is also important to understand. So these things are and once if by any reason if you happen to log out and if you have to log in again, then just put a WhatsApp in the TISA 24 group. We will try and enable you. You will be missing out those many number of questions at that point of time, but that is beyond anybody's control. In the virtual world, we can't help it. That is how we have been doing so, and we shall try and keep that errors as minimum as possible. We have given enough requests for people to join to register themselves. There are few requests even now that I want to join, I want to do this, all that. Please understand, there is always a time frame before which anything can be handled. Just before exam, you cannot come and say, I am a student, I need my hall ticket. So I have given at least 1 month's notice. I have individually called everybody, all HODs. So if somebody has missed out, I can only say I am sorry, we cannot accommodate. So whoever it is unfair on to the other 92 students who have been punctual in doing so, if I accommodate the others who are just coming and knocking the doors at this point of time. So please understand that. Dr. Deep is the joint secretary who is the key person behind conducting all this, and he is supported by all your seniors from all corners of the country. Dr. Subhadeep is here, Dr. Ronak is here, and he will give you the brief introduction. When the actual quiz starts, because it's a ESA program, there has to be some inauguration and other programs which run. The president-elect, Dr. Kotwal, will be also joining at that point of time. When actual quiz starts, the window onto the left side where all this talking is happening is going to be muted, and there won't be any noise from that side so that you don't get any distraction. So only the quiz will keep moving out on the predetermined set time format. So there is no issue in that. So sit in a peaceful room with uninterrupted net connection. You will be able to do good job. So no issues in that. All the best from our side. Do well. We will declare the results at the end of the day that who is going to face for tomorrow. Over to Dr. Deep.
Thank you so much, Hari sir, for taking care of all the logistics. We have another 13 minutes to go. So any of the participants, if anybody having any issues, they can post in the group, the common group. As sir has already said, please ensure you have a good broadband Wi-Fi connection in a nice, quiet, peaceful room. Settle yourself down. All login issues, please handle another 13 minutes to go. Because once the quiz starts, we have no control. If you log in, log out, maybe missing out one or two questions, it can't be helped. The quiz masters have done an amazing job. We have had 11 quiz masters from across the country who have contributed all totally novel questions. They will be there with us. Once the quiz is over, please don't log off. Please stay back for at least half an hour, 45 minutes, because during those time, the quiz masters will be giving the answers. You can cross-check for yourself and the explanation also. And in the end, Dr. Hari Kumar sir will declare the results about the participants who will go on to the next round tomorrow morning. So please don't log off. Please stay with us till the final ceremony.
Deep, good afternoon.
Good afternoon, sir. Warm welcome, sir. We'll be starting in another maybe 2 minutes or so. Am I audible? But my voice is on.
It's okay now.
A very good evening, sir. Warm welcome, sir. We are starting in another 1 minute.
Right. Thank you. We have got 35 contestants.
No, sir, we have lots, sir. We have nearly 100 contestants, and of these, 35 will qualify for the next round tomorrow
Okay.
at the end of the day. So a very good evening to all the participants. They're already online with us for the last 1 hour. We have had our technical checks, troubleshooting. We all have done that. So a warm welcome to all the participants to the Esi Tysa 2024 program. Let me first of all have the pleasure of welcoming our President-elect, sir, Dr. Narendra Kotwal, sir. And let me also welcome our Secretary, Dr. Hari Kumar, sir, who has been the backbone of today's program. All the technical setup and everything has been managed by him. Hats off to him. Let me also have the pleasure of welcoming all the quiz masters, who are all the young endocrinologists of our country from different parts, who have put in a lot of hard work in framing all the original questions. I shall be naming them one by one. Dr. Shahana Shetty, who is currently the professor and head of endocrinology department at KMC Manipal Hospital. Dr. Shubhodip Pramanik, who is a consultant endocrinologist at the Neotia Getwell Multi-Speciality Hospital at Siliguri in North Bengal. We have Dr. Ronak Gandhi with us, who is assistant professor in the endocrinology department at SN Medical College, Jodhpur. We have Dr. Sunitra Mondal, who is assistant professor in the endocrine department at the NRS Medical College, Calcutta. Dr. Pankaj Singhania, who is the consultant endocrinologist at Arogyam Healthcare in Purulia, in the southern part of West Bengal. Dr. Lakshmi Nagendra, who is the associate professor and heading the endocrine department at JSS Medical College, Mysore. Dr. Asfar Fatima, who is the endocrinologist at the Bangalore Baptist Hospital. Dr. Sethu Gupta, who is the assistant professor in endocrinology department at Gangaram Hospital, Delhi. Dr. Shivani, who is the assistant professor in endocrinology at AIMS Bhatinda. So we have good representation from all the four corners of the country. We have Dr. Shinjan Patra with us from Central India, who is assistant professor at AIMS Nagpur in the endocrine department there. And the last quiz master is Dr. Mona Sood, who is assistant professor in endocrinology at Art NT Medical College, Udaipur. So a big thanks to all the quiz master for all the questions. Let me share with all the participants, although the quiz masters have contributed the questions, none of us actually know what question will finally come up. It's all totally scrambled and totally blinded to ensure there is no bias. I think the rules and regulations Dr. Hari sir has already highlighted in the WhatsApp group that today there is no negative marking. But for the first 50 questions, you have less time, 30 seconds. For the next 50 questions, you have more time. And it's a time-dependent marking. So even if you are answering correctly, in a shorter period of time, you actually end up getting some extra marks. It's all being done by the software in the computer. So let me hand over the stage to our President-elect, Sir Dr. Narendra Kotwal, for his words.
Thank you, Dr. Deep, and thank you, and Dr. Hari, all young quiz masters, and dear participants. Welcome to today's this TISA's annual event. An event, as you know, this is an event to assess your clinical knowledge and your skills. And as has been already apprised of, All quiz masters have taken pains to make the questions, and questions are very, there is objective way of assessing the all of you. And may the best person win. I would request all of you, this is a forum to know your other participants in other parts of the country and to forge new friendship. May all the budding endocrinologists, all of you are the future of Endocrine Society of India. Participate in the way its participation should be done, and all the best to everyone. Thank you. Over
Thank
to
you so
Dr.
much. Thank you so much, sir. May I request Dr. Hari, sir, for a few words? Till Dr. Hari is back with us. Any of the quiz masters, we would love to have some input from any of the quiz master, please. Please unmute yourself and put in your views.
Hi Deep, sir. This is Dr. Setu here. Am I audible?
Yes, you're audible.
Hi, sir. Just want to say that it's a very different feeling being on the other side of the table. 2 years ago, I was there. I qualified for the finals, and I remember having a great time. So I'm gonna wish all the best to all of my juniors, and I hope to see the best of you in Bombay. That's all.
We have our current president, sir, Dr. Jabbar, sir, with us also. If he can share a few words with us, with all the participants. So one word to all the participants from our side is that this is not a test of like today, of course, there is no negative marking. You mark whatever you want. But those who qualify for tomorrow, I think it's important to realize not to fall for the negative marking tomorrow. And time is the important factor. I think that has to be kept in mind because this is not commonly we face that even if you know the answer, if you are taking more time, we are actually going to score some less marks as compared to a peer. And ultimately, it is not a test of your full knowledge. It is how we perform under pressure. So maintaining cool, being relaxed, sitting maybe with a glass of water, something to munch also, because it's going to be pretty long process, not to feel hypoglycemic, and make yourself as comfortable as possible. We still have time for the actual quiz process to start. So most of us will stay in the background, and anybody having any issues, they can post us in the group, the dedicated group which has been made for all the participants.
Good evening, Kotwal sir. And good evening, Deep sir. I just wanted to share that to the participants basically that this forum or this activity should be considered as a learning activity, as a paving stone for them that will enable them to learn more and more to the intricacies of how the questions are formed, what we should look at the specific target things that there be in the question that will lead you to catch the diagnosis in the usual clinical scenarios even. So these are the questions that will enrich them, that will help them learn more and more things. So they should be considered as a learning experience rather than being just only a competitive exam, just we have to win that and anything like that, rather than it is a learning experience for all the participants who will be there.
Very well taken, Dr. Ronak. Thank you. I think we'll now be here in the background.
You are muted, sir.
Yeah, I think we will now stay here in the background The last few technical checks which the students are doing, let them finish. We have given a buffer time of 15 minutes to them. We will officially start rolling the quiz at 5:30 p.m. There's a common link. We can use that to see the questions.
चाय शाय पीनी है इन लोगों ने या
One message to all the participants is to reload yourself, reload the screen so that you can actually start seeing the quiz. All participants are requested to reload the system.
हाँ 11 बजे मैं 11 से 12 बजे तो 11 बजे कर लो 11 नहीं तो जल्दी करो मैं 11 बजे तो मुझे उधर पहुंचना है या तुम अपनी गाड़ी होगी तुम गाड़ी तो मैं क्या तुम अपना जो भी टाइम लेना है
नहीं उसने 10:30 के बाद गर्ल्स विल बी देयर बट दे वुडंट वांट कि गर्ल्स आए और साथ में ही मैं आता
तुम अपना टाइम दे जो दोनों वर्षामध्ये आपला फिजिओलॉजी ऍक्च्युली वर्ष मोहन काही मी ऍक्च्युली वर्ष ऍक्च्युली रक्षा not Russia.
Botwal sir, kindly mute yourself.
वो बाहर से आ रही है।
Sir, you are unmute.
Hello. Good afternoon, Deep sir. S- s- Sir, the questions will come here in the Zoom platform because
It will come. We are all blinded to it. We are currently live on the main quiz. Once the quiz charts, it will reach to all of us. Don't worry.
thank you, sir.
So a request to all participants, we are just 9 minutes away from starting the actual quiz. So any queries, please post in the WhatsApp group now, because once the quiz starts, there will not be much to do. It will be in auto mode. And anybody who is not able to see the screen or the screen is stuck, please refresh it. It will start working. Good evening, all. It's 5:27 p.m. So I think we are starting the quiz. So 1 or 2 minutes plus minus, we are starting it now. Gautamji, we can start the quiz.
Done, sir.
I think we are done with the quiz. So we can now, around 15 to minutes to 20 minutes will be taken to compile the results by the backend technical team. We will use this time to discuss the answers for all the questions. Different quiz masters, one after the will share the questions and discuss. So may I ask Dr. Sunetra to take over to answer the first 25 questions for the quiz. Thereafter, Dr. Sahana Shetty will take over from question 26 to 50. And then Dr. Shinjan will take over for the remaining questions.
Sure, sir. So should I start?
Yes, please. Please go ahead.
Okay. So starting with the first question, which is not a component of grade score. So obviously the answer is TPO antibody because this is for Graves' disease and remission prediction, and we use the TSH receptor antibody, not TPO antibody. The second question was, all of the following are constituents of HDL molecule, or rather parts of the reverse cholesterol transport except. So LCAT, CETP, all of these are enzymes of that pathway, and peroxide has a role in that pathway as well. Vitamin E does not so much fall as a part of this pathway. Antibiotic, which has been proposed as calorie restricting mimetic and has shown a longevity benefit, of course, rapamycin, inhibitor of the mTOR pathway. All of the following are 17 ketosteroids except corticosterone. We know that if you look at the steroidogenic pathway, we know 17 alpha hydroxylase is not required for the formation of corticosterone. Then which is not an appropriate indication for the use of HbA1c, which is an appropriate indication for the use of HbA1c in the diagnosis. So of course, for patients with acute pancreatic damage or pregnancy or children, it is not. So the answer is MODI. Next is, all of the following are components of MEN4 syndrome except. We know it's like MEN1, but CDKN1B mutation, and apart from parathyroid adenoma and pituitary adenoma, there can be uterine tumors. So the answer was astrocytoma. Next was about the SONIX trial. So this was for levoketoconazole. Kilpatrick's kludge is an easy method of converting. We know the -2 rule. So this is for glycated hemoglobin from percentage to millimole per mole. Which of the SGLT2 inhibitors has the highest urinary glucose excretion per day? The answer was canagliflozin because it has additional SGLT1 inhibition as well. Fezolinetant is approved, FDA approved for the treatment of, so last year it was approved for treatment of vasomotor symptoms due to menopause. It is a neurokinin 1 antagonist. Which is not a disorder of HDL cholesterol. So the answer is cytosterolemia. We know it is a disorder of phytosterol, increased absorption and excretion of phytosterol due to ABCG mutations. Which does not cross the placenta. So this was easy. We know TSH does not cross the placenta. TRAB, propylthiouracil and iodine does. Next was about the Nobel's paradigm, which is related to puberty. So it is about the GnRH pulses and how it goes on to stimulate gonadotropin secretion during puberty. Which is not a determinant of intrauterine growth. We know growth hormone does not have much of role in any role in intrauterine life. Which is a pan-PPAR agonist. So lanifibranor, which is being tried for NASH. So aleglitazar and elafibranor are dual agonist for PPAR alpha gamma or alpha delta. Lanifibranor is a pan-agonist. So which trial demonstrated that co-administering ARB with an AC inhibitor can increase renal dysfunction? So on target. So after this, the combination was discouraged. It can lead to increased renal dysfunction and also possibly hyperkalemia. Most abundant IGF binding protein overall and most abundant during intrauterine period. So overall, we of course know it is IGF-BP3 and during intrauterine period, IGF-BP1. So C was the right option. Insulin icodec has which fatty acid chain attached with the C terminal? So it's a C20 fatty acid. The Fontaine and Rutherford classification system, this is for peripheral arterial disease. These are clinical classification systems based on the pain and what distance of walking and whether rest pain is present or not. Autonomic neuropathy does not cause which of the following? So, of course, hyperhidrosis was one of the most obvious answers because we usually expect hypohidrosis. All of the following causes hypercalcemia except, so again, thyrotoxicosis addisons are very well-known causes of hypercalcemia. Even pheochromocytoma can cause. So Cushing's does not cause hypercalcemia. There are some reports of rather it causing hypocalcemia. Which gene is not involved in the genetics of osteoporosis? So COL1A5. So for osteogenesis imperfecta, it's not 1A5, it's 1A1 or 2. The rest we know LRP5 is for osteoporosis pseudoglioma, DKK1 also for some form of juvenile osteoporosis with some malformation, and PLS3 for an X-linked osteoporosis. Highest thrombogenic potential is present in which generation of progesterone? So third generation progesterone like gestodin, norgestimate, they have higher thrombogenic potential than the others. And World Osteoporosis Day is celebrated on, so the answer is C, 20th October. I should stop sharing?
Yeah, you can stop sharing so that I'll share. Thanks. Okay, so let's go on to the next question. So the next question is for continuous glucose monitoring in pregnancy with diabetes. What is the recommended target range for blood glucose for which the time in range is calculated? And we know the range is different as compared to a non-pregnant state, and it is 63 to 140 milligram per deciliter. So the next question is, which of the following paraganglioma is not a part of the kinase signaling pathway cluster of the genes? So here we have, for the kinase signaling pathway clusters, we have MM127, RET, NFN, and also HRAS. VHL is not a part of the signaling, so the answer is VHL. Dense disease is characterized by all. Again, we know as symptoms, they can have proteinuria, hypercalciuria, and hematuria because of renal stones. The mutation here is chloride channel 5 and not chloride channel 7. So the answer is chloride channel. So the answer is D, that is CCLN7 mutation. The next question is diagram score is developed to predict. The answer is, we know this scoring is to predict the remission of diabetes following Roynek's gastric bypass surgery. The target follicular phase progesterone level for women with congenital adrenal hyperplasia who are trying to conceive. Here, the target cutoff is less than 0.6 nanogram per ml. It's a slightly difficult question, I understand. It's very easy. So the next question is very easy. Who is considered as the father of thyroid surgery? We all know it's Theodore Kosher. To the next question is a new molecule we know, teplizumab, which was approved to, which is developed to delay the onset of symptomatic type 1 diabetes, so the criteria or the criteria where we can use this molecule is, the answer is age more than 8 years with stage 2 type 1 diabetes. We know that it is shown to prevent conversion to stage 3 type 1 diabetes. So answer is B. So we know there are 5 major somatostatin receptor subtypes, 1 to 5, which is expressed in various organs. Which one of the following combination of subtypes of somatostatin receptor is most commonly expressed in growth hormone secreting pituitary adenoma? And again, a very simple answer: somatostatin receptor 2 and 5. And we know these are the receptors just targeted for therapy. The next question is, which of the following association between the layer of adrenal gland and hormone secretion is incorrect? Again, it's a very straightforward. We know in fasciculata, both glucocorticoids and aldosterone is mentioned is option C, which is incorrect because aldosterone we know is only from zona glomerulosa. So answer is C, zona fasciculata. The next question, the Bethesda system of classifying thyroid nodal histopathology we know was revised in 2023. So compared to the earlier version of 2017, which class nomenclature has remained unaltered? And the answer is Bethesda 2. Next, let us look at the next, that is, which one of the following correctly describes the catecholamine content of the adrenal medulla? And here the answer is D, that is adrenaline 80% and noradrenaline 20%. So that's predominantly adrenaline, which is present in the adrenal medulla. Next question is, 6-year non-diabetic male child presented with history of multiple episodes of fasting hypoglycemia, which is associated with seizures, routine biochemical analysis and cortisol axis is normal. So then the patient is planned for a fast test and observations. What is the duration or how many hours of fasting is appropriate at this age? And the answer is C, 20 hours. So we know it's different for children versus adult. Now look at the GPCR, that is G protein coupled receptor, the new GRAFS system of classifying this GPCR, that is glutamate, rhodopsin, adduction, physyl secretin system of classifying GPCR. Now, according to this class, the highest number of hormone receptors belongs to the category of rhodopsin. So answer is B. All of the following can be useful surrogates to distinguish between thyroid hormone resistance and TSHoma, except now we know SHBG, ferritin, and PRNP may be helpful, and the answer is serum TBG, where it cannot, where it is not cannot differentiate between the two conditions. Now, all are seen. The next question is, all are seen in hypophosphatemic rickets except dental abscess, taurodontism, thin hypoplastic enamel, amelogenesis imperfecta. So the option here is C, thin hypoplastic enamel, which is incorrect because the hypoplastic enamel is a condition which is seen in hereditary vitamin D deficient rickets and in hypoparathyroidism, where you have calcium abnormality, and not in hypophosphatemic rickets. Amelogenesis imperfecta is a dental phenotype of inherited hypophosphatemic rickets. So for this question, answer is C, thin hypoplastic enamel. All of the following are risk factors for new onset diabetes after transplant, except, so it is hypokalemia. Whereas ABO mismatch, tacrolimus use, and hypomagnesemia are risk factors for NODAD. Syndrome of apparent mineralocorticoid excess is a cause of low renin, low aldo hypertension. Apart from the inherited cause, we know that there are some drugs which can cause these conditions. Out of this, thalidomide has not been reported to cause syndrome of apparent mineralocorticoid excess. So answer is D, whereas carbaxolone, bortezomib, and bisphenol A can cause a syndrome of apparent mineralocorticoid excess state. The next question, the recommended dose for dexamethasone suppression testing in children for overnight dexamethasone suppression, low dose dexamethasone suppression test, and high dose dexamethasone suppression test are respectively. The answers are in microgram per kg. So here the answer is A, 15 for ONDST, 30 microgram per kg for LDST, and 120 for high dose dexamethasone suppression test. Again, that's a very easy question. Coming to the next question, which of the following is not a criteria for diagnosis of IgG4? Here again, the straightforward, the serum IgG4 cutoff, which is mentioned in the criteria, is more than 140 milligram per deciliter. So that's the wrong one here. The rest of the one, which is characteristic pituitary histopathology or pituitary MRI showing cellular bars, stage of pituitary mass on glucocorticoids are mentioned in the criteria for diagnosis of IgG4 related hypophysitis. Next, coming to the next question, that is, identify the two statement about Paget's disease. Here we know the answer is it is caused by mutation in sequestome gene, that's sequestome 1 gene. So the answer is C. It's not the most common metabolic bone disease would be osteoporosis. Predominant, it has both lytic and sclerotic lesions, and of course we know that skull, pelvis are the most common affected site. So the answer is C. The next question is, growth hormone is secreted in pulsatile manner with around 5 to 10 pulses seen in a period of 24 hours. Now we know that women have higher growth hormone levels compared to men. Now, what are the other factors or conditions which is associated with increased growth hormone secretions? So amongst this, it is answer is D, that is type 1 diabetes, where there is increased growth hormone secretions, and they have a low and they have a high IGF-1. with aging, there is decrease in growth hormone. Again, with increase in BMI, there is decrease in growth hormone, and exercise increases growth hormone. So lack of exercise it should decrease the growth hormone. So the answer is type 1 diabetes. All of the following factors can cause falsely high CGM readings than the actual glucose values. So again, here the answer is vitamin B12 because it does not interfere, whereas acetaminophen at more doses more than 4 gram, ascorbic acid at doses more than 450 milligram per day, and hydroxyurea can interfere and cause falsely high readings on CGM. Now, the next question is all are true about levoketoconazole except we know that it inhibits multiple enzymes in the synthetic pathway, CYP11, B1, 17, alpha hydroxylase, and also cholesterol side chain cleavage enzymes. It is less hepatotoxic. So the answer here is A. It is a purified, it is 2S and 4R isomer of ketoconazole. Now it's difficult to remember this, but the other these three things we know are correct. So that's the way probably we need to get this answer. The next question is, which of the following is the latest drug to receive US FDA breakthrough therapy designation for the treatment of NASH? And answer is pegozafermin. It's a glycopegilated analog of FGF21, which in 2023 was given as a breakthrough therapy designation by FDA for treatment of NASH. In this question, we noticed that here the question was all of the drugs are associated with proximal RTA, and we noticed that all of the drugs can cause proximal RTA. So for this question, all the contestants are going to get full marks. The next question is all of the following were advantages of trabecular bone score by DEXA over aerial BMD testing, except. So here again, the answer is B, TBS can be calculated even one vertebra. We know TBS is a textural index based on the DEXA L1 to L4 images. So, the incorrect answer is TBS calculated with even one vertebra, but the others are correct because we know TBS is not affected by degenerative spine disease. It gives a better idea about microarchitecture as compared to aerial BMD. And TBS is one of the modifications or corrections of tracks to predict the fracture risk in type 2 diabetes. So the next quiz master is going to answer the subsequent ones. Thank you.
Thank you, ma'am. So I'm sharing my screen. Okay, am I audible and visible?
Yes, you are audible. Please carry on.
Yeah. So the next question was all of the following are seen in histopathological examination of adrenal myelolipoma. So mature fat and erythroid cells and megakaryocytes we all know can be found in myelolipoma. Immature fat has not been described. Next question is all about all of the following are advantages of prazosin over phenoxybenjamin for the pheochromocytoma preoperative preparation. So we all know prazosin is a short-acting, so obviously it's correct. And the alpha adrenergic inhibition by prazosin is reversible. About the blood-brain barrier crossing, it's exactly the opposite, which is told in the option. So phenoxybenjamin can cross the blood-brain barrier, whereas prazosin cannot cross. So that's why it is the answer, which is the correct answer, which is not the correct, which is the wrong answer here. And the prazosin causes the less post-operative hypotension. That is also a correct statement. About the teprotumumab in thyroid eye disease, we have all known in the optic trials. So it has been used as 8 doses, 3 weeks apart. The first dose was relatively less at 10 milligram per kg, and the subsequent doses were 20 milligram per kg. So we need to know the interval of 3 weeks. About usage in ketoconazole in Cushing syndrome, it's one of the most important medical therapy. So the all are false about ketoconazole except, so it was a true statement we need to identify. So the first option is that it has got direct effect on the ACTH secretion from the ectopic sources. Multiple case reports and studies have provided evidence on that. Next option, that it action faster than metyrapone, it is basically false because it is slower than metyrapone. The transaminase seen in the ketoconazole is irreversible, so that's why again it's a false statement. And lastly, about increases LDL, it is also false. It can increase triglycerides, but in lipid profile, it generally having a decrease of LDL that can go in range of 30 to 40%. About familial hyperaldosteronism, it was almost a straightforward. We all know that FH3 is of KCNJ5 mutation. About secondary diabetes in acromegaly, all are true except, so the wrong statement we need to identify. Obviously, the determinants are high GH and IGF-1. Suppression of blood flow in adipose tissue significantly increases the insulin resistance. Again, very correct response, correct statement. Increased IGF-1 does not decrease the peripheral utilization. Actually, it increases the peripheral utilization. That's why many of the hypoglycemic disorders can be IGF-1 or IGF-2 mediated. But in acromegaly, even IGF-1 decreases the utilization due to the insulin resisting effect of the GH, and also with high GH, the hepatic glucose output increases along with the insulin resistance in the adiposity, the secondary diabetes ensues. Last option is also correct, that pasireotide selectively inhibits SSTR5 compared to SSTR2. All of the following statements about hair cortisol measurements are correct except, so we need to identify the wrong statement. First statement is obviously correct, and which is one of the most important advantages of measuring hair cortisol. Dyeing of hair affects the cortisol values. That's why in a patient we are trying to get hair cortisol need to avoid dyeing of hair in recent times. All of the studies which have found 2-3 studies, randomized control studies, hair cortisol have a slightly more sensitive and specific, but most of the studies have done in only LCMS system, but they have been associated with pretty high inter-individual variability. So that's why it is one of the disadvantage of using hair cortisol. About pediatric low bone mass except definition, we need to identify the wrong statement. So first statement is obviously correct. This is one of the primary prototype definition, the presence of any fragility fracture, non-traumatic vertebral fracture, and CD options are correct, like more than 2 fractures by 10 years and more than 3 fractures by 19 years. But the BMD Z-score has to be less than -2 to be called as a pediatric low bone mass. This is a very recent guidelines published in acromegaly, where according to the 14th acromegaly, the recommendation which is following the incorrect, most important changes what have happened, that the GH suppression or the glucose tolerance test suppressed GH has been almost called off. These cutoffs of 0.4 and 1 is not valid now. So IGF-1 of more than 1.3 is the most important thing for diagnosis. Whenever we get an equivocal value of IGF-1, we can go for OGTT and see the GH value. But yes, random GH measured after overnight fasting has got a prognostic value, and the BMI based cutoff should be considered in the GH OGTT groups. Next patient is the 33-year-old man referred to endocrine clinic for his uncontrolled blood pressure despite being on antihypertensive medication. He has got a positive family history and diagnosed to have aldosterone producing adenoma. So which has been following gene mutation has been recently been developed. So this, the correct answer is KCNJ5. One of the Chinese articles, original article they have published about KCNJ5, and they have found out very interestingly these patients are having poor baseline values or baseline cardiovascular values at the starting of the treatment, but after successful operation, they have a very good outcome, and especially the left ventricular parameters improvement are very significant in this KCNJ5 mutation. This question, the 22-year-old woman known to have an aggressive GH tumor, and she was awaiting radiotherapy after incomplete cure achieved with transphenoidal surgery, has a strong family history, and that's why one of the most important gene mutation, the AIP, is associated with such mutation, typically young onset acromegaly, very aggressive, very faster onset, and a very poor response to both surgery and radiotherapy. This is the stages of type 1 diabetes along with the teplizumab has been approved. And for the pathogenesis, the type 1 diabetes was postulated by the Eisenberg. The rest scientists are also associated with various immunological therapies and the immunological pathogenesis of the type 1 diabetes. But for this, Eisenberg was the most important person. This is a very interesting picture of Fuji-Tech. So this is the most important picture which measures the sole pressure in a diabetic foot. This instrument is used to measure the sole pressure, and the 10 to 15 is the optimum value. We should keep it at the footwear. This is one of the novel long-acting basal insulin. Among the options, this is the Epsitora Alpha. This has not been approved yet. This is going under phase 2 trial, and this has been compared head-to-head with the Degludec. So it is combining with the novel single-chain IgG2 FC domain, and this can expected to come in the recent times. Among the procedures, so this is basically the sperm extraction method. So we can see the scrotum, the testis, and this is one of the micro-TC can be performed in like Klinefelters, like endocrine conditions to have a fertility. Next, this was an easier question. We all know about the pathway of the from the pre-opiomelanocortin to ACTH and ultimately to alpha MSH. So this arrow was the corticotropin-like intermediate peptide, the CLI. This was a 40-year lady presented with a recurrent admission of hyponatremia, and we can see there is no such pituitary tissues are also very scantily are present, and obviously by the options, the panhypopituitarism is the option. This was also a slightly difficult one, but still we can remember the first discovered glucose secretion from the liver. This was by the Claudia Bernard. A 42-year male with a diabetes mellitus started on a new drug, which is a curve A, and compared with the curve B for placebo. So the drug responsible is SGLT2 inhibitor, because initially with usage of first 1 to 2 months, there will be a decrease in EGFR, and gradually it have a prolonged and sustained benefit in the EGFR compared to the placebo. This all we know, it's a Barrett index. It is one of the most important index for measuring the muscle hypertrophy in a case of thyroid-associated eye disease. And various cutoffs have been used. Mostly 60% is one of the cutoff has been used to measure the muscle hypertrophy in thyroid eye disease. This is a PAS score, and this is a structure, biochemical structure of epinephrine, where the images, this is mostly about the pheochromocytoma, where more than 4 score is very suggestive of a metastatic potential. This graph shows a hormone over 24 hours during a feeding study. So we can very importantly observe that just after the meal intake, it is going drop. And then again, just before taking a meal, it is going steadily increasing. So obviously we can rule out that leptin, cholecystokinin, and GLP-1 have a typically increasing after the meals, and ghrelin just acts opposite. So this the correct option is ghrelin. The next is also pretty straightforward. A CT scan having plain and contrast, and after the enhancement images. So obviously no changes with the contrast. Typically very smooth border and almost a necrotic masses can be seen inside the adrenal, and also with the hypodensity. So the option is obviously adrenal myelolysis. This picture is of a cleidocranial dysplasia. So we can see that there is atrophy of the sternocleidomastoid. There is a cleidocranial dysplasia is seen. So the option is cleidocranial dysplasia. The Eunice-Varron syndrome in this regard is quite similar to cleidocranial dysplasia, but they can have a severe neurological abnormalities and enamel abnormalities as well, and not that severe cleidocranial abnormalities, but they can be associated with the similar abnormality here. But the option here correct is the cleidocranial dysplasia. So this is a patient of a diabetes and hepatomegaly. So we can see this patient is definitely suffering from hypogonadism. Some form of gynecomastia can be seen, and altered pigmentation is there. So among the 4 options, the hereditary hemochromatosis correctly fits the diagnosis. This is about a very classical skin condition in a patients of diabetes. So we can see circular veil-like lesions, elevated kind of lesions, which we can see in the chest photographs. So the differentials are practically tinea corporis and granulomannularly, but the tinea corporis lesions are typically associated with some scaling, and it will be most dryness of the skin. But obviously with this picture, we can't identify that thing. So obviously the granulomannularly is the option here. This may be a slightly difficult question. A 19-year-old presents with an antalgic gait. So we can see a severe mesomelic. We can see a mid-lung deformity in both of the photographs and a severe deformity of the radius. So obviously the differentials here are between Langer mesomelic dysplasia and the Larybel disc chondrosteosis. But obviously the disc chondrosteosis is the option because there is a very severe mid-lung deformity, and also it's a very severe the deformity of the radius also. So that also can be quite clinching compared to the mesomelic dysplasia. Mesomelic dysplasia will not be that deformed, and they typically have a very short stature, and the rhizomelia, the mesomelia will be very marked in those diseases. This is a very interesting case of 12-month-old infant because of excessive weight gain and hyperphagia with a SD score of +13. No syndromic disease were found, and workup revealed homozygous mutation of LEPR gene mutation. So this is an extremely rare case of LEPR mutation disease, which is a cause of monogenic obesity. It is autosomal recessive, which was recently, a few years back, published from AIIMS Delhi by Hiaborom et al. So this was a very interesting case. This is another very interesting case. This case having a patient of a hearing difficulty with a diabetes, And in the family diagram or the pedigree diagram, we can say this is a mitochondrial inheritance, because only when the mother is involved, the future generation has been involved. So obviously in a mitochondrial diabetes, the cardiac arrhythmias, myopathy, and pigmented retinal dystrophy can be seen. Renal cyst is a typical finding of a MODY 5. Obviously, that is not a mitochondrial disease. This is another question we can have a good idea when we are seeing the eye, because it's a very classical cave ring along with the basal ganglia calcification, and also a very classical rachitic changes in the knee joints along with the knock knee. So this was a case of a Wilson's disease. This question, a little bit tougher one, a 22-year female with a high HbA1c, acute pancreatitis, and a very high insulin need. So obviously we can see the insulin resistance and acanthosis nigricans. This picture shows about the ovarian cystic abnormalities, and the retinal photograph shows the drusen abnormalities, typical yellowish hue, and some hemorrhagic spots with the drusen abnormalities. So if we connect these dots, this is a very classical case of a familial partial lipid lipodystrophy, where the systemic manifestations, the ophthalmological manifestations can be rare. It's only reported in few cases, but with this high insulin need, with low in a younger age, and with the classical cystic response of the ovary, this disease can present in such way. This is much easier, where the external calcification has been found in both over the eyelid and in the knee region, and also in the X-rays. So this is a case of a calcinosis cutis. So the Galanty mutation is the answer here. This is a very interesting case. So this is basically osteopathy striata. So we can see the striated lines in these knee X-rays. And also this is a very classical, it's more like a WNT disease and presents like a Paget's disease. So it's a cranial synostosis, presents with a cranial nerve palsy. So obviously ophthalmoplegia will be in manifestations, CTNNB gene mutation, which is a WNT related gene, and it's very common in females. But in the radionuclide accumulation, it will be increased during the bone scanning. This is another straightforward hyponatremia, hypotension through imaging and histopathology. So obviously it's a case of adrenal histoplasmosis. We can typically identify by this histology, this bluish thing. And the option is obviously the antifungal drug of oral itraconazole. This is a case of a slipped capital femoral hip epiphysis. So these arthritic conditions can have many endocrinological causes. Obviously, hypopituitarism and hypogonadism is one of the leading causes. Hypothyroidism can also cause, but there is no such association with hypoparathyroidism has been described with the SCAV. The histological picture, this is a very classical nuclear enlargement, nuclear elongation overlapping with the chromatin densing. So this is a very classical histological picture of a papillary CA thyroid. This is another very interesting question. This is aphresa, the inhaled insulin. So the incorrect statement was the onset of action is 2.5 minutes. It is not as short as 2.5 minutes. These take around 8 to 10 minutes up to 15 minutes to start action. It increases the chance of hypoglycemia in smokers, and we need to do pulmonary function test before initiation and annually thereafter. And the glucose infusion rate profile showed an early peak compared to the subcutaneous insulin. This is the molecule. This is a chronocort. So this is a modified release molecule, chronocort. So this has been used in congenital adrenal hyperplasia. Mostly it is marketed in Europe, and this is given as 2/3 dose in the night at bedtime and 1/3 dose at the morning. So this was basically discovered and marketed to follow the natural circadian rhythm of cortisol. But in CH, what we use mostly as hydrocortisone or prednisolone, this doesn't follow the cortisol rhythm mostly because we need to give the higher dose in the morning. So it generally weans off. And when the patient wakes up at the morning with very few cortisol levels, with very low cortisol levels, so the patient can go for adrenal insufficiency. For that reason, particularly, chronocort can be very essential, but obviously it comes with various side effects and disadvantages. This is Mealy's angle, very important for arches, what we need to understand in diabetic foot. So we need to mark the correct statement. The first is identifying collapse in the transverse arch. This is a wrong thing. It's obviously the longitudinal arch. Next is to be measured in weight-bearing lateral view. The third is the angle between the long axis of talus, and it's the base of the first metatarsal. But the last statement is correct, the pathological, if it found in more than 4 degrees. This is a very kind of a general knowledge question. So anyone who's seen this film, he is Werner Troyer. and his height was only 82 centimeter, who played a very important and significant role in Minimi in this film, Austin Powers, The Spy Who Shagged Me. So he suffered from contour dysplasia, and he was obviously one of the very interesting choice for this role in this film. Another very interesting patient, an 8-year-old boy with a small for gestational of -3 SD, having relative macrocephaly and feeding difficulties. Very important clues is the frequent nighttime sweating and the hypoglycemic episodes. But very interestingly, we can see in the picture, if you show the right arm, the right lower arm, the right upper arm, we can see there's a hemihypertrophy or the disproportionate arms in the left side compared to the right. So this is a very classical case of a Russell-Silver syndrome, which presents with a small for gestational age, having a macrocephaly and sweating and hypoglycemic episode. This was a straightforward saltpeter appearance, presence in all of the disease like hyperparathyroidism, myeloma, and CKD-MBD. Thalassemia was the obviously answer. This is an ultrasound of the kidney showing the nephrocalcinosis. So papillary necrosis, dense disease, and oxaluria can all cause these things. So obviously, none of the above is the answer. This is a molecular structure of metformin, which can be seen in this picture. This was a very interesting question of auricular calcification. So any case can lead to hypercalcemia, adrenal insufficiency, or acromegaly can cause this auricular calcification, but Cushing's has already been described earlier also. It's not a cause which has been associated with hypercalcemia. Maybe it can cause hypocalcemia. So this auricular calcification doesn't seen in Cushing's. This is a straightforward question. This is obviously glargine, glycine and arginine residues in the B chain. This lesion in MRI, this is basically cleft, Rathke's cleft cyst, so very homogeneous, not taking any contrast, and a very enhanced in the T2. So obviously this is a cleft cyst, and obviously macroadenoma and cystic adenoma can be ruled out. Another very interesting question, the Lorenzo's oil. This was a landmark movie where a case of adrenoleukodystrophy was treated with Lorenzo's oil. So obviously we all know that in adrenoleukodystrophy, there is accumulation of the very long chain fatty acids. So adrenoleukodystrophy is a racemic mixture of a glycerol acid, which can reduce the amount of very long chain fatty acids. But till now, the Lorenzo's oil, it has been there for 10 to 15 years in market, but was not of that efficacious in adrenoleukodystrophy. This is another interesting question of patients with primary infertility with decreased facial and pubic hair with normal height and no anosmia. The MRI sella was very classically shown as a pituitary hypoplasia. The last question is the most more interesting. So this is one of the NovioSense, is one of the non-invasive continuous glucose monitoring devices which can measure the glucose from the tear fluid. So this is one of the coming age technologies, can be used as a non-invasive measures for the glucose monitoring. So that's it from my side. Hopefully all have done very well. So thank you for that.
Thank you so much, Dr. Sinjan. Thank you so much for all the quiz master for taking so much time and making such beautiful questions. Let me now hand over the session to our secretary, sir, Dr. Hari Kumar. We have Jabbar also with us here.
Good evening, everybody. And first of all, my sincere apologies from the Endocrine Society for having some issues technically, because actually the reason why this happened is only because a lot of times the issues were concerning about the majority of people answering correct, and they was to eliminate the subjective bias. We wanted to put the timer also in place so that you get answer correct and answer fast, so you get the correct position in the to qualify further. But unfortunately, the system is not playing up in the correct way, and possibly some of the candidates have not able to log in or not able to have refresh, and so there were some issues in this. So I'm sure most of you would have seen the poll, would have participated in the poll, where more than almost 40 to 45 students have said that they face difficulty with about 20 odd or more than 20 questions in answering this correct. So Professor Jabbar is here. We discussed internally about conducting this. I do have the result sheet with me, but it is incorrect for me to say any result about such an exam. So that is why, on behalf of president, I am just saying that we are delaying this. This is, you can consider that this is a practice exam. The actual question exam, we will reconduct this in better framework, in better platform. After evaluating that, we will come back to you. It will happen very soon, but we will have it with a, I would say, more robust platform than this, so that the same, what do you call, things are not repeated or same issues do not exist again further. So, Jabbar sir, your final comments. We are not going to declare any result for this. My apologies to the students, number one, and to all the quiz masters who have actually put in a wonderful job. But nevertheless, we will definitely have some more in pipeline in the near future.
Good evening, my dear friends. With a little pain, okay. My team, starting from Haribai, Deepdatta, and entire team was very, very active, and they were putting a lot of effort for conducting this show with full justice. Because of unexpected, probably little unforeseen situation, certain technical hinges happened. So we had to take a decision like that in consultation with my entire team. And we'll do it better, and we'll do full justice to TISA program probably within few days. Okay. Once again, on behalf of entire team involved, extremely sorry for whatever happened, and we'll definitely will correct it. Especially my team, Dr. Deep, for the last so many days, that boy was behind this show. Okay. Deep, personally, I'm very sorry for that. Okay.
We should
Anyway,
recognize all the quiz masters also.
yeah,
All of
correct.
them are here.
They were
I mean, they have framed such wonderful questions. My job was more
beautiful. Beautiful questions, and they've conducted, and I think they have taken a beautiful images. They have taken a lot of effort, and questions, standard of question, it was marvelous. So everything, it was fantastic, fabulous work. But technical problems, say that can happen anywhere. Again, sorry, I'm handing over the mic to my friend, Dr. Haribai. Please, Haribai.
Thank you, sir. Dear students, we shall update in the group very soon about the new dates. Tomorrow there won't be any exam, so you can have a great weekend. So we will possibly have internal discussion, and then I'll come up with the dates and the fresh set of how to go about. But very soon, maybe in a day or two, you will get the updates very soon in the group. Thank you all. Have a great weekend.
Thank you. Thanks to everyone. Thank you so much.